Ventricular tachycardia. Etiology. Number 1. Occurs in acute MI syndromes of accelerated rhythm that deteriorate. Example, Wolff-Parkinson syndrome, Wolff-Parkinson-White syndrome. Metabolic acidosis, especially lactic acidosis. Electrolyte disturbances. Toxicity to certain drugs such as digoxin or isopril. Number 2. A life-threatening dysarrhythmia that originates from an irritable focus within the ventricle at a rapid rate. Number 3. Because the ventricles are capable of an inherent rate of 40 beats per minute or less, a ventricular rhythm at the rate of 100 beats per minute may be considered tachycardia. Analysis. Rate usually between 140 to 220 beats per minute. Rhythm usually regular but may be irregular. P wave not present. PR interval not measurable. QRS complex broad bizarre in configuration, buoyant greater than 0.12 second. T wave usually deflected opposite to the QRS complex. Management. First point. If the patient is alert and not hemodynamically decompensating lidocaine hydrochloride, xylocaine is administered as a bolus. This is followed by a continuous lidocaine infusion. Number 2. If the patient is witnessed and the patient is unconscious, administer a precordial blow. Number 3. If the patient loses consciousness and pulse, immediate defibrillation is indicated. Number 4. If the patient remains alert and drug therapy is not working, then synchronized cardioversion is applied. The purpose of cardioversion is to abolish all cardiac rhythm and allow the normal pacemaker the opportunity to capture the rhythm. In some cases, ventricular tachycardia may be refractory to drug therapy. Non-pharmacologic treatments such as endocardial resection, aneurysectomy, anti-tachycardia pacemakers, cryoablation, automatic internal defibrillators, and catheter ablation are alternative treatment modalities. Number 6. An atypical form of ventricular tachycardia referred to as polymorphous ventricular tachycardia or Torsades D points can result as a consequence of drug therapy, that is quinidine therapy, or electrolyte imbalance such as hypomagnesemia. It is important to differentiate this atypical form because its therapy differs from that of the more typical ventricular tachycardia. Under this, A. Torsades D points is characterized by a QT interval prolonged to greater than 0.60 second, varying RR intervals, and polymorphous QRS complexes. B. The treatment of choice is administration of magnesium sulfate 1 gram IV over 5 to 60 minutes. C. If the patient loses consciousness and pulse, defibrillate. D. Ventricular pacing to override the ventricular rate and hence capture the rhythm is also an acceptable treatment. E. Procainamide is avoided because its effect is to prolong the QT interval. The alert ventricular tachycardia is a life-threatening and its presentation calls for immediate intervention by the nurse. And the ECG rhythm will be in this.